Hello, everyone. Welcome to the University of Toronto Joint Centre for Bioethics Seminar Series. My name is Andrea Bianchi, and I'll be the moderator for today's session. Our speakers today are Dr. Nathan Robert Howard and Dr. Eric Mathison, and this seminar is entitled, How Informed is Informed Refusal? Before I introduce today's speakers, I'd like to let you know that the seminar is being recorded. This lecture, along with other archived lectures, can be accessed through the Joint Centre for Bioethics YouTube page. The format of our seminar is a presentation by our speakers, followed by a facilitated discussion period. We wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous peoples from across Turtle Island, and we are grateful to have the opportunity to work on this land. Now, it is my pleasure to introduce today's speakers. Dr. Howard received his PhD in philosophy in 2019 at the University of Southern California under the direction of Mark Schroeder after receiving his MA in philosophy at the University of Toronto. He sees himself as a full-service ethicist with interests in metaethics, normative ethics, and applied ethics. He's currently teaching an undergraduate seminar on informed consent, and his Fundamentals of Reasons, co-authored with Mark Schroeder, is forthcoming with Oxford University Press. Dr. Mathison was a clinical ethicist for Alberta Health Services before joining as a faculty member at the University of Toronto Scarborough campus. Currently, he continues to do clinical and organizational ethics, consulting for health systems and companies in Canada and the United States. He was a postdoctoral fellow at Baylor College of Medicine and has a PhD in philosophy from the University of Toronto. Eric's research interests include assisted dying, the goals of medicine, and clinical practice. Nathan and Eric, on behalf of the JCB, welcome to today's seminar, and I'll let you kick it away.
Okay, thank you very much. And thank you everybody for coming. This is our first kick at the can, the maiden voyage of this talk. So we're looking forward to getting all your comments and feedback. We'd love to know how we can improve. What we want to do today is discuss a kind of supposed or alleged symmetry between informed consent and informed refusal. So to begin with, it's useful to think about kind of the power of consent, that consent is this transformative thing that in the healthcare setting, if I were just to walk into somebody's hospital room and cut open their knee, then that would be assault and I would be doing something deeply wrong. But consent transforms that action. If I were a medical doctor, that doing that action, getting consent from them, and then performing that action makes it totally okay. There's nothing ethically controversial about that, provided that valid consent is given, and maybe some other conditions are met. And this is not just something about healthcare. This is something for ethical sex. This is something for contracts. If you want to take out a loan or join the military, or lots of other things. That consent has this transformative power that moves something from the kind of wrongness, a wrong type of action, to something that's totally morally permissible. As people who worked in bioethics know that multiple criteria must be met for valid consent. So the standard criteria that come up in bioethics discussions, the way that we often teach it in undergraduate bioethics courses, is that there are 4 criteria. That the patient has to have decision-making capacity. They have to be able to understand information, be capable of receiving information and making decisions about it in an informed way. They actually have to get information, and then they have to understand it, be able to reason about it, think about the alternatives. And then their consent also has to be done voluntarily. So if somebody comes up to me in a dark alley and says, your money or your life, even if I hand over my wallet, I haven't done so voluntarily, and therefore that wasn't valid consent. So all 4 of these criteria must be met in order for it to be valid consent. For our purposes today, we're not going to talk about voluntariness. Our main focus is on information and understanding. We're going to kind of focus on both of those. We have some cases where individuals don't have decision-making capacity, but we're not going to really say anything about what capacity is. refusal is often treated symmetrically to consent, that there are, I think the kind of default assumption that people have in bioethics, and I've seen this in clinical ethics, is that that there is a symmetrical thing called informed refusal, and informed refusal needs to take place in order for the refusal to be valid. Now, there's evidence from this in a few different places. This is from California, the court instructions that they give to jurors. I'll just read out a little bit of this, but it's called informed refusal, and it says that a healthcare practitioner must explain the risks of refusing a procedure in language that the patient can understand, and give the patient as much information as they need to make an informed decision, including any risk that a reasonable person would consider important in deciding not to have the medical procedure. So that is described in exactly the same way that we would describe informed consent. A person has to be given the information, they have to understand, it has to be the material information to the decision, and so on. There's lots of stuff in the risk management space in healthcare about the importance of getting informed refusal and then documenting it in the patient's chart, that if a patient is trying to leave against medical advice, then the healthcare provider should try to provide them with the information that they need to tell them about what they're giving up, what they're refusing, and then document those discussions in the medical chart. And in other legal contexts, this is the consent page from the CMPA in Canada. And to read the highlighted part, they say that in the same way as valid consent to treatment must be informed, so it may be argued a refusal must be similarly informed. Physicians thus may be seen to have the same obligations of disclosure as when obtaining consent, that is, disclosure of the risk to be accepted. And though the CMPA's language here is kind of hedgy, they say that it may be seen to be this way, that the context of the article shows that they think that it does actually need to be taken this way. So there's a very common view that informed consent has these criteria, and then informed refusal has similar criteria. In fact, that it's symmetrical. The one applies to the other. Our main point, the thing that we want to argue in this talk, is that there's in fact an asymmetry, that consent and refusal are asymmetrical, and the main way that they're asymmetrical is that the information condition, information and understanding that applies to valid consent, doesn't apply to refusal. So in order to give valid consent, there are the information and understanding criteria. Those criteria do not apply for something to be valid refusal. That is the main claim that we want to argue for today. So if a patient refuses something, that their refusal is valid, even if they haven't been given the same amount of information as they would have needed to be given in order for their consent to be valid. So if I'm going to consent to a knee surgery, I need to be told, what the surgery entails and the recovery time and what the alternatives are and so on, whatever that set of things is. But if I'm going to give valid refusal to the surgery, I do not need to be told the same set of things. The bar is not as high. So our goals here are twofold. We want to convince you that the asymmetry is correct, that the conditions of informed consent do not apply to informed refusal in terms of information and understanding. And we want to explain the asymmetry. So we're going to kind of philosophize and try to give an explanation about what's actually going on, not just that there is this asymmetry, but we want to give a philosophical explanation about why the asymmetry exists and why this is not actually a problem, that this is actually totally fine. This is a good thing. Before proceeding, want to flag that we're approaching this from kind of a philosophical bioethics perspective. So Nathan and I are both moral philosophers. I've worked in clinical ethics and have a background, and we're going to talk about a couple or discuss some cases based on consults that I've done. But especially in terms of the law, this is not legal advice, and in terms of the medical discussion that we're going to give, that we're framing this in kind of a broader context besides just the Ontario health law and health ethics framework. We're happy to hear your thoughts if there are kind of situational things from the place where you work or what you've seen. Please let us know. But we're trying to approach this in kind of a philosophically focused way to try to give kind of philosophical understanding while still pointing to the kind of practical upshots. So what I want to do now is talk about two different types of accounts of consent and explain the one that we're going to go for. And this is really going to kind of set the stage for the rest of the discussion. This gets a little bit in the weeds in terms of the basis of consent. So I want to flag that. The purpose of consent, like why we care about consent in ethics and in the law, is that consent is a mechanism. It's a process that we use for promoting autonomy. So autonomy, this is our claim, this is a common claim, that autonomy is the value that we're trying to promote, and consent is the mechanism by which we promote autonomy. So when we have, in order for something to be valid consent, it requires information because of autonomy. That the basis of requiring information in consent is that it's autonomous. So to kind of explore this a little bit further, we're going to draw on Tom Doherty's work. And he says that there are these two different types of understanding that the individual must have in order for them to give consent. And the first one is what he calls description understanding. And this is a pretty low bar. That description understanding, to meet that, is just that you can describe what the intervention is that you're going to receive. So if I'm going to receive a knee surgery, then it amounts to basically saying, I'm going to receive knee surgery. And the rest of the details, don't need to be met. Now, the basis for the description understanding, one of the reasons for that is what Doherty calls an intentionality rationale. So consent, in order to give valid consent, that is not the sort of thing that you can do by accident. You can't kind of stumble your way into giving valid consent. When you give valid consent, you know what you're doing. You know that you're giving consent to a thing. So that's what intentionality is aiming at, that there's something kind of, that it is on purpose. And this aspect of it, this is actually symmetrical with refusal, that if you refuse something, you are also doing that on purpose. You can't really refuse by accident or, oh, it turns out I refused that thing and I didn't even know I was doing it. Instead, refusal is something that you do on purpose when you do it. So that's not a difference. The second reason for the description point is that what Doherty calls a targeting rationale. So this is, you're not just consenting in general. When you consent to something, you're consenting to a particular thing instead of some other set of things. So if I consent to knee surgery, I'm consenting to the knee surgery and not to other types of surgery. So this is also something that applies to refusal, that if I'm refusing something, I'm refusing a particular thing or a particular set of things. I'm not just refusing in general. There is a thing that I'm refusing, and that's the kind of specifics of it. So both of these factors apply. These parts are symmetrical between consent and refusal, the description element to it. But Doherty says that there's also what he calls a context understanding. And he describes this as understanding when a person has context understanding when they understand the action's purposes, the risks and benefits, as well as similar information concerning relevant alternative courses of action. So this is a higher bar. It's not just knowing that I'm consenting to knee surgery, it's knowing that the purpose of the knee surgery is to do X and Y, that there are risks and benefits to it, that there are other things I might try, including doing nothing, that there's going to be a certain amount of recovery time, and so on. And so this is a higher bar in that there's a lot more information or a lot more stuff that the person needs to understand. And this is the way that we think that the difference between consent and refusal is that to refuse something, you need to have the description understanding, but you don't need to have the context understanding. Refusal doesn't set the bar as high in terms of having all of that information. You don't need to know what the risks and benefits are of the refusal, what the alternatives are, and so on. So context understanding, that although Doherty's kind of calling it a context understanding is his own label, but that will be familiar to everyone who's worked in healthcare. But this is the kind of the way that we think that refusal comes apart from consent, is that there's no context understanding requirement for refusal in the way that there is for valid consent. Now, just by way of kind of like saying a bit more about the basis of the nature of consent and refusal, that the approach that we take is deontological, thinking about consent in terms of rights, and this connects most nicely. This is, I think, the standard view that it connects to autonomy. The basis of consent is that it's autonomy is a means of promoting autonomy, as I said before. So this is what's called often called the proprietary gate account. That when you consent to something, you are consenting, or when you consent to somebody doing something to you, you are waiving your moral right against that person performing the act. So, the status quo, if I'm just living my life, is that there is I have a moral right against somebody performing knee surgery on me. But when I give consent to the surgeon, I'm waiving my moral right. I'm saying, okay, now you can go ahead. Before, it would have been impermissible. But by giving consent, that is the transformative power of consent. I waive my right, and it's now permissible to have the surgery done. It's permissible for the surgeon to proceed. Now, the reason we bring this up is that we want to note that there's an alternative that's sometimes called the evidentiary account of consent. And this account focuses on well-being. When you consent to something, the kind of basis for consent is that it promotes well-being. And now this is also a plausible story much of the time, that the reason consent is valuable, or in addition to autonomy, is that we know ourselves best most of the time, and so we will be best placed to know what's going to promote our values, and also our well-being. So this is a plausible account. The reason, though, that and on this account, that information is necessary for refusal because it promotes well-being. So this is actually kind of perhaps an explanation about why people treat consent and refusal symmetrically, is that if information is an important part of consent because it'll promote our well-being, then information, you might think, is also an important part of refusal because it will promote our well-being. If we're refusing something and we don't have the information, then that could make us worse off in terms of our well-being. So this is a potential explanation for why people are tempted by the symmetry view. Our reason for focusing on autonomy instead of well-being is that we think that in refusal cases, autonomy trumps well-being. That to give it, like standard Jehovah's Witness refusing a blood transfusion type of case, the basis for us respecting that refusal is that they are making an autonomous decision. Most people do not think that the burden is on the person doing the refusing to have to show that that refusal is going to be in their best interest in terms of their well-being. In fact, the kind of like basic, like what makes those cases kind of get attention is that many people think that that's not in their well-being, not in their best interest. So we think that in refusal cases that autonomy trumps well-being. And so given that, we should reject the evidentiary view. We should reject kind of any appeal to well-being as a reason for overriding it. So this leaves, there's an open question here that autonomy trumps well-being in terms of refusal, but then you might wonder, well, then why with consent do we need context understanding if we don't need context understanding for refusal? That is, if autonomy trumps well-being in terms of refusal, why not think that autonomy also trumps well-being in terms of consent? So this is an open question that we have to answer. And when we switch over to Nathan, he's going to take a shot at trying to answer this for us. What I want to do now is discuss as a kind of descriptive point, like what is the difference between refusal and consent? I've been talking about kind of some of the justificatory bases for this, but I haven't actually said anything about, as a descriptive point, what the differences are. And this turns out to be important, and it requires us to kind of to go through some cases and to be a little bit fussy about it, that we think that it's important to describe the cases in the correct way. And we think that part of the explanation for why the symmetry view is often believed is that it's by the way that people are kind of thinking about what these cases are, what it means to refuse something and what it means to consent to something. So I'm going to turn to that now. The first point that I want to argue for is that refusing something is not the same as withdrawing consent or consenting to the withdrawal of some treatment or procedure. So to give you a basic case, imagine a patient in ICU who's attached to a ventilator who says, doctors, I would like to be removed from the ventilator. Please unplug this ventilator and let me die. So that's what the patient is requesting. Now, I think that it's tempting to think about this as a case of refusal, that the patient has now started refusing the treatment. But actually, we think that the best way of framing this is not in terms of refusal, but rather, it's refusal in kind of a different sort of way. Most accurately, what the patient is doing is withdrawing ongoing consent. So it can either be that she's withdrawing ongoing consent, or she's consenting to the stopping of the intervention, which had been ongoing. Don't really have kind of a pick between those two, even though they're slightly different. So why should we think this? Why is this a case of withdrawing ongoing consent? Well, imagine that somebody went into her room and removed the ventilator without her consent, just went in and unplugged it and she died. This would be battery or assault and maybe homicide. And so what this shows is that if she hadn't consented to it, what this shows is that consent was required for the removal, or that withdrawing of consent of the kind of ongoing ventilation was a requirement of the permissibility of it. Merely removing it, taking it away without the patient's consent would be deeply wrong. So the status quo is in favor of the continuation of the ventilator until she consents to its removal. So we think that this is a kind of first kind of clarification sort of thing, is that that this type of case, removing a ventilator and other cases like it, that these are cases that are best captured in terms of withdrawing consent or consenting to withdrawal, not refusal. But there are other cases I'm going to go through. So one of them is, we'll call it informational refusal. So in this case, a patient requires heart surgery, requires it to stay alive, or heart surgery is indicated. The surgeon comes into their room and begins to describe the procedure. The patient interrupts, saying, "No, thanks, doc. Keep it to yourself. I'm not interested. I don't want your heart surgery. Leave me alone," basically. Now, our view is that the patient is allowed to do this. The patient does not want to hear the information, then they can do that. And they aren't obligated to listen to the surgeon. And when they do that, they are giving, they are refusing, and that should be respected. It's a valid refusal, even though they haven't been given the information that would be required for them to give valid consent. So refusal in this kind of case has what we're going to call a signaling role. That it would be impermissible to perform the surgery, and the reason is that the patient has not given consent. That this is the kind of standard explanation that without consent, or in the absence of consent, you can't proceed with the surgery. So refusal is signaling that the patient has not given this consent, and that's what makes it wrong to proceed. But the information threshold, we think in these cases, does not need to be high at all. They know that they're refusing the surgery, but they don't need to get any of the information at the same level that they would need to get in order to give the refusal. Here's another case of a similar flavor, call it surgery refusal. In this case, a patient is found to have a serious blockage that could cause an aneurysm at any point. The doctor recommends beginning the workup for the surgery immediately, but the patient waves her hand and says, "That's okay, doctor, I'm going to take my chances without the surgery." The doctor hasn't yet explained that the aneurysm would likely kill her, so the patient isn't informed in the sense required by valid consent. Now, what is obligated here, or is this a case of valid refusal? We say, yes, the patient is allowed to do this. She does not need to hear all of the details. She's not required or obligated to listen to the doctor in order to give valid refusal, whereas she would be obligated or is required to listen to the doctor to get the information and to demonstrate understanding in order for it to be valid consent. I want to just say an aside here, which is that the doctor is still, we think, still obligated to offer the information, to say, listen, I really think you should hear this information before you refuse, before you walk out of the hospital. I need to tell you this. And that is an important thing. The doctor should make an attempt to talk to the patient, to give them that information. But we think that this is best explained in terms of the professional obligation that the physician has to offer the information, not because the patient needs to be giving valid refusal, or that the information is necessary for it to be valid refusal. So the doctor should still try to say, you had this aneurysm, can I give me 1 minute, let me just try to explain this to you. But if the patient says, like, no, I don't want to hear any of it, then there's no kind of further step. The doctor doesn't have a further role to play once they've tried to give this information. Still valid refusal. Okay, another case, vaccine refusal. This is a low information case. So an employer decides to incentivize employees to receive an experimental vaccine. Like really experimental. The risks, benefits, and alternatives to the vaccine are unknown. They just mixed a bunch of stuff together and they want to inject it into people. One employee, Sam, wants no part of the experiment. Whatever the incentives offered by the employer, Sam refuses the vaccine. Once again, Sam is allowed to do this, even though the decision is uninformed. We don't really know anything about the vaccine, so the level of information is not established. So in all of these cases, refusal plays a signaling role. And the signal that what it's signaling is that there's an absence of consent. So this is the in each of these things that we think that there is a refusal going on, and it's justified, that the refusal is kind of sufficient. But one might object at this point that there's kind of there's a problem, that uninformed refusals, that they're not properly autonomous. And this would be kind of the sort of argument that people would make about, uninformed consent is not properly autonomous. So if uninformed refusals are not properly autonomous, then they can be overridden by appealing to hypothetical consent. That is that if the patient had more information, then they would decide differently than what they're actually deciding. And that gives us the basis for overriding their uninformed refusal. We shouldn't kind of take them at their word. We'd be justified in interfering. Now, we think that this is a mistake. And the basis for this is that we think that the real refusal is more autonomy promoting than hypothetical consent. That when there's a tension between a patient giving an actual refusal, saying, no, thank you, I don't want that, I refuse, and considering that to some hypothetical version of them, where if they had more information or they were thinking about it in a different way, they might consent, we should go with the real refusal. This is not there's lots of justification for this in the philosophy of literature, both in bioethics and elsewhere in political philosophy. So this is a quotation from Isaiah Berlin, who says that once I take the view that people are acting against their true selves, and so that lets us kind of interfere with them, I am in a position to ignore the actual wishes of men or societies, to bully, oppress, torture them in the name and on behalf of their real selves, in the secure knowledge that whatever is the true goal of man, happiness, fulfillment of duty, wisdom, just society, or self-fulfillment, must be identical with his freedom, the free choice of his true, albeit submerged and inarticulate self. David Enoch has a similar quotation. I'm just going to skip that and go to a quotation from Jessica Flanagan, who is written on in Bioethics, and says that whether a fully informed and rational person would consult with a physician or regulatory agency before making a drug choice is quite a separate question from whether he would endorse being coerced to comply with experts' recommendations. So the idea that Flanagan is pointing to is that if we think about this hypothetical person with full information and full rationality, that what they might agree to is a different question from whether we may coerce them, whether we may interfere with them, and whether they consent to that. So the upshot of that is that we can't override refusal by appealing to autonomy. We might, we could do it, try to make a paternalistic claim or make it a broader claim in terms of public health, say, but we can't do it just by autonomy. Okay, so there's a dilemma that we think our opponents face. So people who are trying to defend the symmetry, they face the following dilemma: that either refusal signaling role exhausts its moral significance, or it doesn't, because refusal is morally transformative. Now, I've just discussed the way that the signaling role might exhaust its moral significance. So that's just kind of everything there is to say. But what opponents need to show, or what people defending the symmetry need to show, is that there is some kind of moral transformation that occurs with informed refusal in the same way that there is with informed consent. That's the kind of power of informed consent, that it transforms. So far, in all of the cases that I've described, there is no such transformation. Rather, refusal just maintains the status quo. If the patient doesn't want the heart surgery, then that just maintains the status quo, and the surgeon's unjustified in doing the surgery. So it just keeps things the same. There's no transformation that goes on. So that's the hunt that we need for symmetry, is to show that there is some kind of transformation in order to show that symmetry is correct. The final thing is that, so this means that the basis of this is that there's a standing negative right, so a right not to be operated on. This is the basis of, if you're in the hospital room, a person can't just come in and perform surgery on you without your consent. You have a standing negative right against interference, and it's only by giving consent that it transforms what would otherwise be wrong into the permissibility. Okay, so that's what we're searching for, is a case of transformative refusal. And with that, I'm going to switch it over to Nathan.
Right. So do I have the right screen showing?
Yes, you do.
Excellent. Okay. Thanks for that, Eric. So what Eric has just done is provided our argument against the idea that in a lot of cases, refusal needs to be informed to play the signaling role, showing that there's an absence of consent. And really what's doing the moral work in those cases is the fact that there's no consent. And so those cases fail to vindicate the idea that refusal needs to be informed, because uninformed refusal can signal an absence of consent. So
Sorry,
on behalf
Nathan.
of our, yeah.
Yeah, now something's going on with your screen. We can't see the full slide. I can just see the top of it.
Oh,
It was
weird.
working for a moment there. Oh,
how are we doing that?
Yeah, that looks good.
Okay, great. Thank you. Thanks for cutting me out. Okay. So what we're looking for on behalf of our opponents now is cases where refusal is actually doing work in creating, making an otherwise permitted act forbidden, right? In the other cases, it's just the default that, let's say, knee surgery is forbidden unless there's consent. And what refusal is doing is saying there's no consent. So it's not really doing any moral work. The kind of cases that we really need are cases where the intervention is kind of by default permissible. And so if there's an issue, if someone issues refusal and that succeeds in making the intervention impermissible, then refusal will have done some real work. And then we can assess whether that refusal needs to be informed in order to really successfully make the otherwise permissible intervention impermissible. And we can think of sort of three cases that fit the bill for this. Cases where, once again, the key point, the key difference with the cases that Eric mentioned is that the intervention is by default permissible. So whereas in the experimental vaccine, giving experimental vaccines willy-nilly is impermissible, or in the heart surgery, performing heart surgery willy-nilly is impermissible, absent valid consent. The kinds of cases we're going to look at now are ones where the intervention is by default permissible. And so if the patient issues refusal and the refusal makes the intervention impermissible, then the refusal is out. And then we can ask whether that refusal needed to be informed to do that work. We kind of have three cases. So taking somebody's blood pressure is not commonly thought to require their consent. Nevertheless, it's at least pro tanto wrong to take a patient's blood pressure when they refuse to allow you. We don't think that the moral force of this refusal, that making the pressure taking impermissible, is blunted by their ignorance. The refusal stands even if you learn that they don't understand, let's say, the benefits and risks and alternatives to taking one's blood pressure. That is when the patient lacks what we've been calling, following Doherty, context understanding. And at least one of us, that's to say me, is tempted to think that taking someone's blood pressure against their will is particularly wrong when the patient is ignorant of the procedure's risks. Although the diagnostic procedure is harmless, largely harmless, the patient may not know it. And so the perceived risk, or their perceived risk of the treatment, counts against imposing that procedure, the diagnostic, against their will. So because taking a patient's blood pressure does not require their consent, an absence of consent cannot explain why it's impermissible to take their pressure or take the blood pressure of a patient who refuses it. So this is a good kind of case for showing that uninformed refusal retains its moral force. If an uninformed patient refuses to have their blood pressure taken, then that refusal holds, even if it's otherwise permissible to take their blood pressure. We think something similar is true of higher stakes interventions. So consider the well-known case of Millett versus Shulman. In that case, Georgette Millett, a Jehovah's Witness, suffered severe injuries in a car accident in June 1979 and was immediately taken to the hospital. The defendant in this case, Dr. Shulman, determined that Millett's life could be saved only by administering blood transfusions to compensate for her profuse bleeding. However, despite knowing that Millett had clearly indicated in a card that she did not want any blood transfusions under any circumstances, the doctor went ahead and provided the treatment. Millett sued the doctor, claiming negligence, assault and battery, and religious discrimination. And the court ruled that the Jehovah's Witness card effectively restricted the doctor's right to provide treatment to Millett. The Supreme Court of Ontario upheld the decision, stating that Millett had made her objections to blood transfusions known to the physician in the best way possible. And unless there was evidence to the contrary, her instructions should be followed. So we agree with this rule. Not only was it legally wrongful to administer this transfusion, it was also immoral. And moreover, other things equal, there is no right against refusing a blood transfusion when you arrive unconscious with injuries like Millett's. It's standard and accepted procedure to give a transfusion. So Millett's case has the right kind of structure to test whether uninformed refusal retains refusal's more general power to transform something permitted into forbidden. And now we could explain the absence of a right against blood transfusion in two ways. One in this sort of hypothetical consent way, but that has already been covered by Eric's cases. So I think we might understand the absence of such a right against blood transfusion paternalistically in the best interest standard kind of best interest kinds of standard. So let's imagine that the reason why it's permissible in the Millett case to at least prima facie permissible in a case like Millett's to give a blood transfusion is because it's in the patient's best interest, right? They will die unless they get the blood. So according to our opponent's view, if Millett is not adequately informed, her refusal lacks moral force, and the physician does no wrong in continuing to administer the blood transfusions. But we think that this is still wrong. Millett's refusal seems to have a distinctive power, making the otherwise permissible blood transfusion impermissible. And this holds even if it seems plausible, Millett lacked context understanding of the risks, benefits, and alternatives to blood transfusion. The moral power of her refusal is not contingent on her understanding of these things. We think more mundane or perhaps more common cases share this structure. The procedures involved in resuscitating a patient, for example, do not, for obvious reasons, require the patient's consent. But we think that DNR orders make such procedures impermissible, even if the patients giving those orders lack context understanding. So just by way of recap, I think much of the intuitive support behind the idea that refusal must be informed to be valid rests on several confusions. One is a confusion with the withdrawal of consent, which may require information to be valid, but tells us nothing about refusal. And there may be many cases where refusal seems to play a central role in explaining whether a procedure is ethical, but these are actually explained by the absence of consent. And further, refusal can play this role even when it's uninformed, that is, of signaling an absence of consent. So that ends the case-driven argument for our thesis. The implications for our opponent's view that valid refusal requires informed refusal are simply not borne out by the intuitive judgments about the relevant cases. So we'll now return to exploring some of the palatable consequences of our opponent's view, if it were true, and conclude by sketching an explanation of why refusal and consent differ in the information that they require, if we have time. Okay, so now we're going to sort of imagine what symmetry between refusal and consent would impact. What would happen if our opponents were right in thinking that there were symmetrical informational constraints on refusal and consent? We suspect, as we've already mentioned, that a lot of the motivation for thinking that disclosure requires being informed to be valid actually comes from confounding a medical worker's duties of disclosure with a duty for a refusing patient to be informed. It's highly plausible that workers, medical practitioners, physicians, nurse practitioners, and so on, have a duty to disclose relevant information when a patient refuses treatment. And we suspect that some of the concerns voiced above about requiring that patients give informed refusal to avoid malpractice risks are actually just misstated. The better understood concerns about discharging one's disclosure duties when a patient refuses treatment. But discharging this duty doesn't require that the patient understand or otherwise accept the disclosed information. You can discharge this duty as a practitioner, even if the patient sticks their fingers in their ears and yells, la, 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 la. So we're not examining duties of disclosure. We're concerned with the distinct, though related question of whether refusal needs to be informed to be valid. We think we've argued fairly exhaustively that uninformed refusal can be valid. The informational demands of valid refusal are asymmetric with those of consent. We tried to outline some of the conclusions for the seemingly widespread impression that only informed consent is valid. Confusions involving the withdrawal of consent, or just as we just mentioned, duties of disclosure. But let's imagine what would happen if our opponents are right. A considerable amount of our art rests on the intuition voiced by Berlin, Enoch, and Flanagan that ignoring someone's refusal because it doesn't meet some standard of information amounts to a kind of tyranny, as Flanagan would put it. And now I get to read the quote that Eric skipped and recall that, as Enoch writes, the thought, for instance, that in real life political disagreement that results in an impasse, you can coerce me, insisting that there's really no problem with my limited liberty or autonomy or some such, because the policy that you're pushing down my throat is one that is approved by my own deeper community, or one that I would accept under suitably described hypothetical conditions. That thought, thinks Enoch, seems entirely ludicrous. And we might say the same thing about medical disagreements between care providers who want to pursue certain treatments and the patients who refuse those treatments. But to bring out the force of this intuition, consider what it would mean to set it aside. Suppose that a patient is in dire need of care, and care that can be administered only at a hospital. But the patient is in their house and refuses transport to the hospital. They certainly don't understand the proposed treatment, and they don't want to go to the hospital. Do we drag them? What's the alternative if we judge that the refusal isn't adequately informed to count as valid? Similarly, what happens if, in our case of surgery refusal, we judge that the patient who refuses both surgery and the descriptions of the risk benefits of surgery is not adequately informed to validly refuse surgery? And that is, do we then forcibly sedate the patient and prep them for ER or for the OR? It seems that, at least to us, in all these cases, if a patient refuses, you do nothing. And that makes the bare act of refusal valid. Our opponents, as I've hoped we've shown, mistakenly think of refusal as the inverse. But if it were, then if a patient doesn't validly refuse, would you do something? This line of argument seems to require action in the presence of invalid refusal. And if that's right, then the informational demands on valid consent are not symmetric to the informational demands on valid refusal. Actually, they're exactly inversely related. For as you raise the bar for valid refusal, you lower the bar for permissible intervention. And if permissible intervention requires, or generally requires, valid consent, you thereby also lower the bar for valid consent. So in sum, by requiring non-trivial kinds of information for valid refusal, it looks like we end up jeopardizing our doctrine of informed consent. It looks like we're forced to intervene when we judge that refusal is somehow invalid. And that's reason enough to lower our standards for what counts as valid refusal. So now I have 6 minutes. And in that 6 minutes, I'm going to try and dance a very, very intricate dance of explaining exactly why the nature of consent and refusal requires different pieces of information. So far we've been relying on the standard fare of philosophical ethics. That is, we've been relying on case-driven intuitive judgments that serve as counterexamples to the idea that valid refusal is informed refusal. These judgments are enough to support our thesis. So if you're with us thus far, that's all we can really ask. If you agree with us that valid refusal requires less information than valid consent, you've grasped the main lesson of this. But another thing that we're interested in as philosophers is explanation. We might reasonably ask why it is the case that refusal is less demanding than consent. So beyond eliciting these case-driven intuitions and tracing their implications, we also aim to offer the beginnings of an explanation of why those judgments, rather than others, hold and how they fit in with the rest of our ethical theory. So we're going to conclude by suggesting the contours of an explanation of why valid refusal requires less information than valid consent. And I hope that the phrase suggesting the contours clearly signals just how sketchy and underdeveloped our proposal is. So what follows might be best understood as a description of future work. Nonetheless, I think we can make the idea clear enough to be worth discussing. And that requires introducing this notion of positive and negative rights and duties. So one of the most central and popular distinctions in deontological theory considers the distinction between positive and negative rights and between positive and negative duties. If you're not immediately familiar with the distinction, it's pretty easy to bring out. A patient requires a heart transplant and you happen to have an unplanned heart on ice, ready for transplant, and further, there's no one else around to give it to, then you have a duty to give the patient the heart. Of course, that duty might be defeated or undercut in various ways, so it may not turn out that all things considered, you should pursue the transplant. But there's still a case to be made that there's a duty to pursue the transplant grounded in the patient's claims over the heart. This is a positive duty, a duty to do something to aid another. This kind of duty contrasts with a negative duty, that is, familiar duty to refrain from causing harm. As Philip Foot and many others have argued, positive and negative duties seem to vary systematically in strength. In particular, negative duties against harm seem much stronger or stricter than comparable positive duties to aid. That is why, famously, you may not cut up one patient to distribute their 5 healthy organs to 5 ailing patients as a flat-footed consequentialism might seem to imply. As Philip Foot writes, it is interesting that even where the strictest duty of positive aid exists, this still does not weigh as if a negative duty were involved. It is not, for instance, permissible to commit a murder to bring one's starving children food. If the choice between inflicting injury on one or many, there seems to be only one rational course of action. If the choice is between aid to some at the cost of injury to others and refusing to inflict the injury to bring aid, whole matter is open to dispute. We can understand the difference between refusal and consent in terms of positive and negative duties. For example, consent undercuts the negative duty against harm. When I consent to surgery, I consent to being cut open. Being cut open is surely a harm, something that's forbidden except in unusual circumstances. That's why I can't operate on someone without their consent. This negative duty is relatively stringent. It's a big deal if someone wrongly cuts me open and fiddles with my organs or my knee or whatever. Refusal, by contrast, undercuts a positive duty to aid. When, for example, Georgette Millette refuses a blood transfusion, she's refusing aid. The kind of duty she stifles with her refusal is a comparatively weak duty. It's a positive duty to aid. And so here's the big, final, controversial thought. It's the idea that the stronger a duty, the better position we must be to overturn it with our will, with our consent, with our refusal, with our agreements and offers and so on. We think this premise has some independent plausibility, so we might want to just leave things there. Say you need to be in a better position with your information to overturn a negative duty than a positive one. But there's some further support we could offer this premise. We might say, well, invalid consent violates a negative right, right? Whereas invalid refusal merely violates a positive right. So violating a negative right is worse than violating a positive right. And the risk of invalid consent is therefore weightier than the risk of invalid refusal, because invalid consent violates the weightier right. And so it's a riskier enterprise to engage in consent. And so engaging in this riskier enterprise requires more information of us. So we recognize that this explanation is sketchy and underdeveloped. Indeed, the place we're going to turn to next is developing it, but we hope we've given you enough to chew on, and we look forward to welcoming your questions. Thank you very much.
Wonderful. Thank you so much for that talk and taking us through the the idea that informed consent and informed refusal are actually not exactly the same thing and shouldn't be treated in the same kind of way. So now it is, of course, time for our Q&A. And so for those of you who are online, if you do have a question, please put it into the YouTube chat. If you're not logged into YouTube or you want to ask a question anonymously, you can send your question to jcb.ea@utoronto.ca. And I believe that email address has been posted in the chat for those of you who are joining via YouTube. And so perhaps I'll just kick it off with a question that is, let me go to it. So at one point in the presentation, and I think this might have been when you were speaking, Eric, it was noted that refusal maintains the status quo and wouldn't be transformative in the same kind of way as an informed consent. And an example was given around informed refusal for heart surgery, and that it's just maintaining the status quo. And so the question is, but what about if a refusal actually causes a decline or a worsening of one's condition to occur? Wouldn't that be a type of transformation that is morally significant?
Thank you for the question. I will take a shot at it first, I guess. Yeah, so I think that it's a good point that the refusal could transform the health status of the patient. Absolutely. In the case of somebody refusing a blood transfusion, I think really clearly indicates that, or a patient refusing to be resuscitated. The type of transformation that we're focused on is the kind of moral transformation, that the status or the sense in which the status quo remains the same is that the standard of all of us living our lives is that people can't come and interfere with us unless we give them consent to do so. And that's the sense that the status quo is maintained. So you can only come and perform surgery on me once I consent to it, and otherwise the moral status quo stays the same. So even though my health will could get significantly worse if I don't go to the hospital, if I'm stuck at home and I refuse to go to the hospital, that the moral status quo is that you still may not come and interfere with me.
Thank you so much. Okay, and so questions are certainly coming in. And so one of the next questions is that it was noted in order to determine, determine if a refusal is valid, does the type of procedure or intervention matter at all? And it seems like your answer to this may be no, but I guess the second part of the question is just, do interventions with riskier consequences associated with a refusal potentially require a more informed refusal in order for that refusal to be valid?
You want me to take it there, Eric? Please. I saw you mouth, please. I mean, on the one hand, the explanation that I will not say offered, I will say pointed at in a fog, seems to suggest that yes, because it's higher stakes, the question asks about how the stakes affect the degree of information required by refusal. The kind of explanation I offered towards the end might suggest that, but I think that there's something intuitive behind that. Nevertheless, I'm not sure. I mean, here I want to defer to my colleague with some clinical experience, but I'm not sure that we make those kinds of fine-grained distinctions in the information required by consent. We just think we need the patient needs to understand the alternatives, the risks and the benefits in all interventions, regardless of whether the risks are mild pain or loss of life. They still need to understand that, and understanding mild pain or understanding loss of life isn't more informationally demanding. One isn't more informationally demanding than the other. So I guess although the explanation I offered towards the end says the higher the stakes, the more information, we're thinking in like a deontological frame. And so the stakes here are going to be not stakes about well-being, but stakes about right. And so in that case, I think just as long as the rights are the same, the information needs to stay the same. But Eric, maybe you want to say that.
Yeah, I think that even as the stakes get higher, that there's no change in the information requirement that the patient has to get in order for it to be valid refusal. That there's the fact that they might not have understood the information would not kind of tip the balance over into overriding their refusal, if assuming capacity and so on. I think that what does change, though, and this is what I think is motivating or what I would say is motivating the intuition, is that the professional obligation to contact. So I recently had a clinical consult where a patient was at risk of dying very soon from an aneurysm, and the healthcare team should go to great lengths to track down that patient out in the community and try to give them that information and try to get them into the hospital. But if the patient doesn't want to hear it, then that's the end of the story. So I think the professional obligation increases, but I don't think that the information or the understanding of the patient needs to change.
Thank you so much. Yeah, I certainly found that quite interesting in relation to the professional obligation and that being actually importantly distinct from what you're asking for with the information. Another question came in around your arguments and how they apply to or perhaps whether they apply to substitute or surrogate decision makers. Can they, namely SDMs, similarly provide uninformed refusal? Do they have obligations to participate in a conversation in order to provide informed refusal? So just your thoughts around that.
That was the concluding slide that I cut off. We're open to thinking about that. We're not sure. I mean, that's an open question. I don't have a good answer for that. I think it's a very good question about whether uninformed surrogate refusal is as valid. Eric and I have talked about this. Maybe once again, I'm going to defer to my colleague. Is that all right, Eric?
Yeah, I will. When we talk about it more, I will try to convince Nathan that that I think the SDM role is different. That the role of the SDM is either to promote the patient's values, so we looking to kind of evidence of that, or to act in best interest. And I think that uninformed stuff, then like what we can refuse for ourselves without information, that's basically up to us. But I think that when we're making decisions for other people, that it's the standard is different. So uninformed refusal would not, it doesn't really apply in the same way. But yeah, we've got a lot more kind of work to do to figure out like exactly what the parameters are. So but the quick answer is I don't think that our view for this maps onto substitute decision makers. I think that we're just talking about patients with capacity deciding for themselves.
Thank you so much. Excuse my voice. Another question has to do with medical assistance in dying and the recent legislation changes in Canada. I assume have led to this question, which is that under Canadian law governing eligibility for medical assistance in dying, it requires, of course, that people give informed consent to receive medical assistance in dying after having been informed of the means that are available to relieve their suffering. On the other hand, in order to qualify for medical assistance in dying, one criterion is that their suffering is intolerable and it can't be relieved under conditions that they consider acceptable. So the question that stems from this is, does an individual's refusal of alternatives have to be informed? And so this is the idea that if a clinician provides the individual with all sorts of alternative options, does their refusal to entertain, undergo, hear about all those alternative options, does it need to be informed, or can it be an uninformed refusal and then they would proceed with MAID potentially? And if you do want any clarification questions as well, if you have clarification questions, we can always post that and then have the person write in.
Yeah. Let me say a thing, and then Nathan can disagree if he wants to. We're doing it live. That I would say that the process of consenting to MAID in those cases involves being told about all those alternatives and understanding them. So I would say that it is. I think that is a case where it's not consenting to those particular things. So to get MAID, you have to be told about those things and say, no, I don't want those, and then it goes through to MAID. But I don't think I think if any of those things on their own were offered, then you wouldn't have to be given information about them. It's a kind of nested point. That's a good case, and we'll definitely build that one in, because I think there could be other situations too where you have to get I'm thinking of like VADs and things like that, where you have to go through like other steps to get to it in order to qualify. So that could be a case, or there might be other cases like that. Nathan, do you want to add anything to that?
No, I mean, only that I think, just as you said, and I think correctly, that this seems to be a case where, although we use the language of refusal, it really is somebody, refusing to give consent. And it's best understood in terms of the absence of consent, not the presence of refusal. And so just standard, yeah, I don't think our view has much light to shed on that. Yeah, but it's an excellent case when we think about it.
Thank you so much. And time certainly flies. I realize that it's 5 o'clock. There's a couple of questions that we didn't get to. And so perhaps if you're comfortable with it, Eric and Nathan, we can send those your way for your own reflections and thoughts on them as you continue with this work. But with that being said, it certainly is time to draw today's seminar to a close. And so I have a couple of announcements to make before we thank our speakers. So our next seminar will take place on Wednesday, April 26th, and this will be Dr. Meena Andiappan. The seminar is titled Me, Myself, and AI, How Interacting with Artificial Intelligence Affects Employees' Expectations of and Attitudes Toward the Role of AI. And so to sign up to receive our weekly seminar reminder emails, please email jcb.info@utoronto.ca. And I believe that this is being put into the chat on YouTube as well. And CSB students who are enrolled in the CSB student seminar course, please do remember to keep track of your attendance. And so with that being said, I certainly want to thank on behalf of the Joint Center for Bioethics and everyone who's attending today and will inevitably watch your presentation in the future. Eric and Nathan, thank you so much for joining us, for presenting your work, and for giving us a lot to think about.
Thanks, everybody.
Thank you.